Yes, thanks, doctors, very much. We had a great roving reporter session earlier, so I'd love to keep the trend going. The next question is, and I'm really excited for this question because I'd love to hear from you all in the audience about your lived experience. The question is, are your patients with IBD hesitant to switch from an IV to a subcutaneous anti-TNF agent? And if so, what is the main reason for their hesitation? Once again, the question is, are your patients with IBD hesitant to switch from an IV to subcutaneous anti-TNF agent? And if so, what's the main reason for that hesitation? Would love to hear somebody's lived experience. Who would love to answer this question? I thought I saw a gentleman over at that table. The back of his head is to me, but I can feel he's...
Talk to Taryn.
Looking for one participant. I think this is a really great question because I would love to hear... Hey. Oh, hey, sir. Hello. Can you stand up for me? What's your name?
Patient won't have hesitation, but I will have hesitation.
Okay, hang on one second. We want to hear what you have to say. Okay. What's your hesitation?
Well, if patient in high dose is not complete remission, I will continue with IV infusion.
Okay, all right. Doctors, any thoughts?
With perianal disease.
Yeah, okay. It's valid.
You
Go
mean
ahead.
at the highest dose, if they were on 10 milligrams per
10
kilogram
milligram,
every
yes,
4 weeks.
yes.
And I think the data you just saw completely agree with you.
Yeah, but that does
that's right.
mean that individuals on standard dosing, 5 milligrams per kilogram every 8 weeks, 5 milligrams per kilogram every 6 weeks,
patient won't have
10
any
milligrams per
hesitation.
kilograms
He will
every
love
8
it.
weeks, or 10 milligrams every 6 weeks. And frankly, most of my patients, it's very few of my patients who are on 10Q4.
Come to New York.
Oh, okay. We tend to stick in the other range. And how would you feel, sir, about one of the other doses? Would you feel comfortable after seeing these data and switching to sub-Q infliximab?
Yeah, of course, yes, I would.
Yeah.
Yeah.
Love getting this dialogue going. Isn't this nice, breaking the barrier, right? Getting the conversation going with the doctors. How about you, sir? I could see you were staring intently. I know you have something to say.
No, I just had a question.
Okay, sure. Can you stand up for me? Would that be all right? Thank you. Sure, hang on. Let me just get the mic.
Similar to how they bridge like heparin treatment with Coumadin treatment, do they ever lower the dose of the IV and give a concomitant sub-Q dose so that they kind of like balance it out? Do they ever have any studies showing that that might help?
Oh, in terms of overlapping?
Yeah.
I can't say that I've experienced that. I haven't done that. I've simply made the switch. I can see what you're driving at, and maybe the timing would work out that way. That you will have given an IV dose, and then in a couple of weeks, when we know there should still be a lot of IV infliximab in circulation, you're giving maybe the first sub-Q dose, and you are sort of doing that in a sense.
In a sense, I know.
Mm-hmm.
Yeah. But your point's a good one in that one thing I have done is when I've had stable patients on higher dose, sometimes I'll say, your level's really good. Let's try bringing your dose down a little bit with IV, make sure you're still doing well, and then switching over to the sub-Q. I have done that in a handful of times.
But the important point is knowing where you're starting.
Right, exactly.
So you need that level. It's helpful to have the level, I think.
Because it seems that your point before about the anti-drug antibodies are at play here. And I think you had a slide that said that the every week dose was a little bit more effective than the every other week. Is that, or did I read that slide wrong?
That was for adalimumab. Yes, for a different sub-Q anti-TNF. I do, if you're using it in ulcerative colitis, it does tend to be somewhat more effective at the weekly maintenance dose.
Because you don't have as many dips. Supposedly, that's the
Supposedly.
theory. So I'm wondering if they have these new technologies out with these pumps. I wonder if there's any work being done with that to get a completely even level and have even less of a anti-drug.
Yeah, I think the real important thing is not to dip too low. So it's okay to have some variation. You just don't want it to go so low that there's almost nothing. And that's a setup for immunogenicity.
Thank you.
Yeah.
Thank you so much. I think he's kicked off our Q&A session inadvertently.
pretty much.
Appreciate it. Thank you so much. I don't think we have any more time for any participation, but thank you so much so far to everyone who contributed. Doctors are going to throw it back to you. And again, please get those questions in for our Q&A, which is coming up. We don't have a lot of time left. So I'm going to throw it back to you. I'm going to talk fast. Go.